Yeah, we've got plenty of time for questions, so please come on up if you have some. I've got one initially, and I'm wondering, this information is both very encouraging because it tells us what we should be doing, but also, kind of disheartening because clearly some people might be being left behind by some of this work. What do you think? Can you tell from the Healthy Community Study if the interventions that are being done in a community are reaching all of the citizens, or whether it's only reaching the white, more affluent individuals?
Yeah. I think that's a great question, and I think is certainly one of the areas for future research. When we looked at each of the community programs and policies, we documented the reach, and that was framed as a generalist question, so we didn't have the opportunity or the time to ask reach to whom, and in retrospect, that probably would have been a helpful question. In some cases, we did ask questions about whether or not the participants in each community program and policy were or affected by were predominantly low income, and whether or not they had a sense of predominant racial or ethnic category that it had an impact on. But we had a higher number of CPPs for which people couldn't report on that. They didn't feel like they understood, or we also suspect that they maybe said all because of wanting to seem equal. So I think that's certainly an area that is a future research opportunity.
Hey, friends. So I have one easy question. In that graph that showed the intensity scores, you had the 130 places.
Mm-hmm.
Do you remember what like the two or three top ones were? Especially that top one that was like, whoop, like they had a really high number of high intensity scores. I'm just curious because I'm always looking for peer cities to figure out what's happening in their politics and their leadership and their communities that's making them be able to tackle those higher intensity, higher complexity, often higher resourced projects. Do you remember what those communities were?
No. Actually, as part of the analysis and the protections of human participants in the work, we were blinded from knowing the actual cities when we got to the analysis elements. So we cannot comment on what communities those were. Okay. Sorry.
Is that related? Do you have a related question there? Because I have another one,
Okay.
which is... So, and Steve kind of answered this, I think, a little bit, which is about the combination of different strategies that you do. Because one thing, it's interesting because I was thinking about the system change stuff that David Renz was talking about yesterday and breaking it up into those three parts. And a lot of the higher intensity ones, kind of hit that, will hit that top one, which is like looking at the policy and broader systems type stuff. But the transmission, it doesn't diminish the importance of the transmission of the behaviors, which is that, right, the part of the system change where you're kind of digging into like, are people we build a trail, are people using it, right, is always the question. We built a grocery store, there's now broccoli in our neighborhood, are people cooking with the broccoli, And so, I don't know, is there like further research to be done about like which combinations, not just like which intensity, but which combinations of strategies in particular might yield the most interesting and impactful results?
Yeah, actually that has been surfaced as one of the ongoing research questions that the investigators have about the data. I mean, we, at the end of our study, really had the time to answer that question of what does it look like and whether or not it's associated with outcomes. So I think as we look forward, we are really eager to better understand the prevalent combinations of things and whether or not those sort of prevalent combinations of CPPs are associated with BMI improvements.
I could add to that. Vicki's team also developed a kind of nomenclature of common language descriptions of things like community gardens. Oh, thank you. Community gardens and the like that I think will be helpful in addressing that and looking at combinations of things as we go. I wanted to underscore a closing point that Vicki made because I think this is, I appreciate the social ecological model and the emphasis in this meeting on that. I think that's necessary for us to be attending to. I also think it's insufficient. The most disturbing finding, I think, for us is that graph that Vicki displayed that showed that these investments, even these high-intensity investments, they're not disadvantaging necessarily to community. They're relative. They appear to be advantaging some kinds of communities. And so we need to, I think, similarly be looking at those intermediary determinants of health, the differential exposures, differential vulnerabilities, differential consequences that produce inequities. And that ought to be part of our conversation as well, because it looks pretty clear that without attending to that, we might improve population health, but we won't affect inequities.
Please.
Hi, thanks. Thanks very much for a really good overview of complex findings. And so this is for either Vicki or Steve, and on the same topic. So as I look at the kind of the race ethnic specific effects, it shows that even at the same level of intensity of intervention, you're not getting the same effects. Mm-hmm. So I'm wondering if you've had a chance to look at, are there qualitative differences in the intervention strategies? Are there, in some communities, are there concentrations in some outcome behaviors, mm-hmm. or in some sectors that might help explain some of these differences? Mm-hmm.
Those are great questions, and I think the answer is no, we haven't had a chance, but I think that's part of the ongoing interest in the investigators.
We had some early hopes mm-hmm. that we could capture. We had some questions for the protocol, for example, that included adaptation for culture and context. Mm-hmm. And those things were jettisoned because, I mean, there was just only so much time we could spend with key informants, and even less that we could extract from documents, right, to understand those sorts of things. So more to be understood.
Mm-hmm. I know later this afternoon we're going to be hearing about Latino health. I serve a predominantly African American population, and I was wondering if you knew about interventions that target their health or any work with the Coalition for Black Health. I can't remember the name of the coalition. There is a coalition, but I can't remember the name.
Sure. I think I was just speaking to our work here in Kansas City, Kansas, and our coalition, that particular coalition has a mission that has been expanded over the last year to look at health equity for all Wyandotte County populations that are experiencing inequity, and have been growing our coalition's membership to reflect both African Americans and Latinos, but that's a recent change, and I'm afraid I'm mostly aware of that, but I think my colleagues from Healthy Communities Wyandotte, as well as Monica from our coalition, might be able to answer that a little bit better. That's a great question.
Any other questions from anyone? I guess the one point, oh yes, Denise, please.
I was just going to say I attended a meeting at SAMHSA on adverse childhood experiences, and so the thought was if you look at these experiences and their relationship to obesity, obviously there's increased rates of obesity occurring, so I wonder in some of the communities, like the African American community, if by coding interventions that are targeted at these experiences, if you might get a more impactful outcome, could there be a synergy between trauma-informed treatment or some of these others, or decreasing exposure to violence or things like that? But, because we're kind of caught up in thinking about providing access to food and physical. Sorry, we're kind of caught up in thinking about providing access to food and physical activity, and I wonder, if these focus in particular communities on these adverse childhood experiences, and if you went in and coded those and looked at the interaction between the two, you might get a better bang for your buck, so to speak. I mean, I know it's probably beyond the scope of obviously what you guys could do, but.
Well, I would say It was definitely a little bit beyond the scope of what we were doing. However, each CPP was coded for the social determinant of health in which it affected, and some around violence, for example, were included as opportunities that could be coded. In general, key informants did not raise those elements. And just thinking about where we sort of, Steve mentioned, we developed a nomenclature to characterize each type of community program and policy, as longer descriptors were eliminated for privacy efforts. And I don't recall any that connected those things, but it's also fair to say that we weren't explicitly looking for that in the context.
That's the issue. And the other thing that we've been aware of too is in a lot of these communities, the kids are, especially like in the summers, are at home by themselves. So even a babysitting program or something, so there could be other ways to start thinking about the types of programs that might need to be in these communities to provide, opportunities for more impactful intervention.
Personally, I think the risk of attention to experienced trauma is that it's kind of a slippery slope to then seeing the deficits and vulnerabilities in individuals and families. Not that you were suggesting that, but I think it's a risk for us. And I think it's incumbent on us to be thinking about what are the environmental conditions that would make it less probable that those exposures would occur for current and future generations. I'm not suggesting you were suggesting that, but I think that represents
But I would say that, for like PTSD, the best treatment is exposure therapy. So in some respects, by ignoring it, it potentially perpetuates it as well, so.
fair.
Not that I have the answer.
Yeah.
The only comment I have related to that is some of our work from systems mapping showed that out of the 260 programs working in childhood obesity in Kansas City, approximately 20 were focused on specific ethnic or racial groups. So there's a clear population that is not being addressed in this type of work. So, if there are no other questions, we'll take a 1-hour break for lunch. This has been a great morning. We had to cut a few short, so if you have questions, please grab the speakers during lunch, and we'll meet back here at 1:10 p.m.